Thank you very much, and hello everybody, and a warm welcome to this session from BMJ. Kieran Walsh is my name. I'm Clinical Director at BMJ. I'm a geriatrician turned editor turned educator, and today we're going to talk about BMJ Best Practice Comorbidity Manager and implementing living evidence in practice, and what we're trying to do to enable the evidence-based management of patients with multiple illnesses, which is not straightforward, but let's start off and see where we get to. So this is broadly what I'm going to talk about. I'm going to briefly mention evidence-based medicine, talk a little bit about BMJ best practice, the challenge of managing patients with multiple illnesses and delivering evidence-based care to them. Going to talk about what we've done with BMJ Best Practice Comorbidities Manager and run through a clinical scenario to demonstrate how it can be used in practice. So first of all, a couple of words about evidence-based medicine. 1992, Gordon Guyatt first coined the phrase evidence-based medicine, and it's the definition of evidence-based medicine has gone through numerous iterations down through the years. But at BMJ, we like this graphical definition of evidence-based medicine, i.e. evidence-based medicine is a mixture of the best available research evidence, but also resources, including practitioner professional expertise, and also patient and populations' needs, desires, and values. And you put all those three together in the center, then you get evidence-based medicine. But there are challenges with that. First of all, the research evidence is often based around patients with single diseases. Professionals are trained often at medical school to manage patients with single diseases, and yet patients all too commonly have multiple diseases. So there's a mismatch, and it's that mismatch that we're trying to address. So the background, BMJ Best Practice is our point of care clinical decision support tool for doctors, junior and senior in primary, secondary and tertiary care, and also for nurses and allied healthcare professionals. It provides content that is structured around the patient consultation, from diagnosis to management to follow-up, and is evidence-based, continually updated, practical and accessible. It's a knowledge resource that should answer clinical questions, but you don't just get any answer. You should get an answer that's focused on what's important to you, our users. And what's important to our users is that they get an answer quickly, within seconds, that they get content that's practical, that they can put into practice to drive improved patient care, that's accessible so that they can get at it on a mobile, on an app, increasingly integrated into the electronic healthcare record. And of course, they want to be assured that the content is continually updated and evidence-based. And yet, there are problems with evidence-based medicine. Here's a long list of such problems, which I won't read all out, but they're from a paper by Trish Greenhaw et al., published in the BMJ a few years ago now, but still as relevant today as they were a few years ago now. The paper is called Evidence-Based Medicine, a Movement in Crisis. And the problems range from information overload through to lack of shared decision-making. And at the very end, evidence-based guidelines often map poorly to complex comorbidities. And we think that this is an important issue, an issue underlying many other problems. And so the reasons why guidelines are inflexible, rules mechanical, prompts technology-driven, is because of comorbidities. And it leads to the refrain that evidence-based medicine doesn't work in the real world. So we think that if we tackle the problem of patients with comorbidities, it could help with lots of the other problems with the implementation of evidence-based medicine. And this in turn led us to look hard at the problem with comorbidities. Comorbidities are common and important, but they're much neglected. I should say that if anybody wants the slides, please do let me know. Let me know your email address. I'm very happy to email the slides to anybody who wants them. So comorbidities are neglected. Here's a quote from Professor Chris Whitty, writing in the BMJ in January 2020. Training from medical school onwards, clinical teams and clinical guidelines all tend to be organized along single disease or single organ lines. And within a few weeks, ironically, Chris Whitty was to become a household name in the UK because of the COVID pandemic, but his initial focus actually was on comorbidities. And comorbidities are a problem not just in the UK, but around the world. Here's just one study actually in Saudi Arabia of MERS and looking at the prevalence of comorbidities amongst hospital inpatients. And they found that 56% of patients had comorbidities. The comorbidities that they had are no surprise. They're chronic, non-communicable, long-term conditions, diabetes, hypertension, heart disease, kidney disease, etc., etc. So we decided to focus, at least initially, on comorbidities in the acute setting. Most patients in the acute setting have more than one medical condition, but clinical resources only focus on single conditions, which is an important sentence. And when comorbidities aren't taken into account, patients get suboptimal care, worse clinical outcomes. In hospitals, comorbidities are also associated with longer lengths of stay and increased costs. And yet there's more problems. 1 in 3 adults suffers from multiple chronic conditions. In the UK, remarkably, 1 in 3 adults admitted to a hospital as an emergency have 5 or more conditions. And people with multiple conditions have poorer functional status, quality of life, healthcare outcomes, are higher users of care, have higher mortality, also tend to be poorer, and if poor, tend to run into problems younger, which all poses significant problems for health systems. And yet, resources for healthcare professionals tend to focus on single conditions. So we thought at BMJ we have to look at this in some more detail. And so we started by talking to residents and asking them if they found this a problem. And universally, they said they did. They found managing patients with comorbidities difficult. They worry they'll treat one illness, which will make another illness worse. They worry that comorbidities might be overlooked. They lack confidence in decision making, particularly at transition points in their careers. And of course, the greatest transition of all is from medical student to resident or intern. We also spoke to senior clinicians, and senior clinicians are worried about junior clinicians, and also healthcare providers and hospitals who were worried about junior clinicians, senior clinicians, and also quality of care and cost. And underneath cost is length of stay and readmissions. So in light of all this, about 18 months ago now, we launched the BMJ Best Practice Comorbidities Manager. And what it is an add-on to our clinical decision support tool, BMJ Best Practice, and it advises how to manage patients with multiple conditions. And how it works is you add a patient's comorbidities to an existing management plan, and then you get a tailored or personalized plan. And thus, it helps healthcare professionals in providing all-important holistic care. So the idea is you have a patient with an acute condition, maybe pneumonia, and you can add one or more of these comorbidities, and you'll get a tailored plan for that patient. And what we discovered is that you get an exponential number of potential comorbidities, and comorbidities are common, and single disease is increasingly rare. I spoke to a cardiologist last year who told me he couldn't remember the last time he saw a patient with a single disease, which I think is very, very telling. And to date, we're the only clinical decision support tool designed to address this issue. So how does it work in practice? Well, this is a clinical tool. So we've put together a clinical scenario to bring it to life and to look at it from the patient experience point of view, which of course is all important. And here is the clinical scenario. Imagine we have a 70-year-old woman who comes to the emergency department with shortness of breath and a fever, has been unwell for a week and has a history of heart failure and depression and is on medications for these. And test and a chest x-ray confirm your clinical suspicion of COVID-19. So you don't need to be a geriatrician to work out the diagnosis here. It's COVID-19, heart failure, and depression. So it's not a diagnostic challenge, and yet it is a management challenge. Let's look and see why. So imagine for a second that the scenario splits in two. And in the scenario on the right, you manage the patient's acute illness and also the comorbidities. What happens? Well, you'll start the patient on steroids for severe COVID, but you'll keep a close eye on the depression because you know steroids can make depression worse. And you'll monitor mood status and maybe arrange psychiatric liaison. In light of the heart failure, you'll keep the fluid status under review. You'll avoid non-steroidals, and you'll keep cardiovascular medications and perhaps renal medications under continuous review as well. That's what you should be doing. Let's look on the left and let's imagine we just focus on COVID-19 and don't think about the depression and the heart failure. What happens? Well, steroids will make the depression worse. Fluids will cause worsening heart failure and fluid overload. Non-steroidals will make that even worse and also cause renal impairment. And if cardiovascular medication are not reviewed, the renal failure will get worse. So what happens? Well, if you don't manage the patient holistically, the patient will get renal failure, decompensated heart failure, and deterioration in the mood. If you do, the patient should improve quickly and should be able to get home. So let's kind of talk through this and think through this, because I know I've moved through it at speed at the interest of time. From the patient perspective, what's happened? Prolonged hospital length of stay, inconvenience, pain, worsening of depression, distress. And from the hospital perspective, there has been poor quality of care and increased costs. The increased costs related to the number of bed days and the type of bed days. And we know that these add up, and we should remember that this is just two comorbidities added to one acute condition. Now you might ask, how common is this problem? And unfortunately, it's all too common. 25% of patients with severe COVID-19 have a history of heart failure. COVID-19 has been associated with depression. And in Saudi, unsurprisingly, like the rest of the world, there's been so many patients with COVID-19. But it's not just COVID-19. Let's look at another example. 60% of patients with hip fracture also have hypertension. Multiple studies have shown a high prevalence of osteoporosis in Saudi Arabia. What happens if you don't manage the hypertension correctly in a patient with a hip fracture? The consequences will be hypertension, postural hypertension, further falls, and heart failure. It may well be postural hypertension that caused the fall, that caused the hip fracture in the first place. So it's vital to manage not just the hip fracture, but all the patient's relevant conditions. And one last study related to COVID, looking at the prevalence of diabetes and COVID-19 in hospitalized patients in Saudi. And the prevalence of diabetes is high, unsurprisingly, but there are other common comorbidities that were discovered, like heart failure, renal failure, etc., etc. all of which were predictors of a fatal outcome. So I know I'm hammering this point home here, but it is a very, very important point. Now, I may do a demo at the end, depending on how we're doing for time. But I'm just going to talk a little bit about what we've been doing with the Comorbidities Manager over the past 18 months and why it might be relevant to you. First of all, we've been evaluating it amongst medical students in simulated scenarios, and they found it to be helpful. And we've been providing it to undergraduate medical students at medical schools, but also to postgraduate trainees or residents as well. Very relevant to CPD and postgraduate medical education and healthcare professional education is CPD points, and we're glad to say that BMJ, including BMJ Best Practice, including BMJ Best Practice Comorbidities Manager, are accredited by the Saudi Commission. And we've also been evaluating it amongst doctors, residents, and more senior doctors. And we asked them to use the tool in clinical practice and tell us how they got on. And they have told us that it is effective in helping them improve care. And here's a number of qualitative quotations that they've sent us, which I won't read them all out, but I'm just going to read out the first one and the last one. Once again, if anybody wants the slides, they're welcome to have them. And the first one, where it talks about using the tool in a patient with acute coronary syndrome and GI bleed, shows the complexity of clinical medicine and the challenge in providing evidence-based care to patients with multiple illnesses and how the Comorbidities Manager can help. And the last one, involving the diabetes specialist team, I think is really all important, because patients with multiple illnesses need multiple interdisciplinary team members to care for them. Just a single doctor is not enough. And here's some more quotes here. We're keen, when necessary, to integrate the BMJ best practice into the electronic healthcare record. There's different levels of integration, from simple linking through to search widget, through to HL7 info button, through to deeper levels of complete API integration. And why do I mention this? It's because that evidence-based medicine will only be possible if clinicians can access the evidence. And what they want to be able to do is access the evidence at the point of care without having to go to another device or shooting up another browser or logging into another system. They want to be able to access it in the system that they're using. And I guess one of the points that I'm trying to make is that evidence-based medicine and the implementation of evidence-based medicine should be inseparable. They should be exactly the same thing. And so accessing it via an app as well is all important as well. And the app has to work well with a fast download time, using minimal storage, and also the BMJ best practice, including the Comorbidities Manager, is available offline via the app. We also sometimes come across the challenge of clinicians needing to follow local guidelines as well as the international best practice guidelines provided by ourselves. So we've got a local guidance tool that can enable that to happen too. And of course, for junior and senior clinicians, the ability to integrate the content within undergraduate and postgraduate curricula is important, and we can do that as well. So I think this is the last slide, or second last slide. What are we trying to do? Ultimately, we're trying to do all these things in the first bullet point, from improving quality of care to saving costs. Much like everyone else, everything else everyone else is trying to do. What makes us different? Well, we feel we have a clinical tool that's designed to help real-life patients with multiple real-life illnesses. And it's trying to do a difficult thing, which is to get healthcare professionals to stop and think. and indeed make a strategic step in evidence-based medicine and clinical decision support, moving from academe to the coalface, from fragmentation to holistic and high-quality care, and from single diseases to comorbidities. Thank you very much for listening. I'm happy to answer any questions that any of you might have about the resource or about anything else that BMJ is doing. This is my absolutely last slide. But my email address here, I'll leave it up there for a second. If anybody wants the slides or wants indeed guest access to the BMJ best practice and the comorbidities manager, please do send me an email. We're very happy to provide that so that individuals can take a look. But I'm going to stop sharing my screen now. I don't know how we're doing for time. Yeah, we're fine for time. And I'm just going to check the chat to see if anybody has any questions so far and on all of that. If anybody wants to find out about how to access, please do send me an email. And Brian Alper has asked, would you like to show a demo, which I think is a good idea. So I just sorry, excuse me for 1 second. Well, I'll see if I can share my screen again now and show you a demo. Sorry, just bear with me. So I'm just going to share my screen again once. And you should be able to see BMJ Best Practice, the homepage. I'm logged in for those of you who are familiar with it. And I'm going to go to COVID-19, like the scenario that I showed you in the slides. And this is all you need to know about COVID-19, from diagnosis, management to follow-up. But in the interest of time, I'm going to go directly to the treatment algorithm to find out how to manage a patient with COVID-19. Just wait for a second for that to come up. And it asks you, does your patient have mild, moderate, or severe? Our patient has severe COVID-19. And so it gives comprehensive evidence-based guidelines on how to manage a patient with severe COVID-19. I won't read it all out, but I'll also ask you, does your patient have any comorbidities? And we say yes, our patient had heart failure and depression. And so we'll say, show the treatment algorithm now. And as you can see, C icons or comorbidity icons have appeared. And I won't click on all of them, but let's just click on a couple. So we'll go to steroids, and it gives guidance on the prescription of steroids. But also, if we scroll down, it says, oh, be careful, your patient has depression. You need to monitor for psychiatric complications of steroids, and it says how and why. And we'll do one last one. Your patient has COVID, you may be considering an antipyretic or analgesic, but it says, once again, a warning, your patient has heart failure. You should avoid non-steroidal anti-inflammatory drugs in a patient with heart failure or kidney failure. So very straightforward and simple things. And yet, when we talk to senior clinicians in the UK and many other places, they say that often they're called to see a patient 3 days after their admission, where patients have been started on antipyretics or non-steroidals, patients with heart failure or with kidney disease, and they have to rescue the patient. And what we want to do is to try and get ahead of that and to stop these problems happening in the first place. I'm just going to stop sharing my screen now. Yeah, I'll add my email address again here. Sorry. Yeah, so there's my email address for people who want to have it. Yeah, I'll just go to, sorry, I think I'm gonna go to Q&As. So thank you, Amani, who's asked, do you have examples in involving BMJ best practice in a medical curriculum? So yes, we have done that in the past in a number of medical curricula, but at undergraduate and postgraduate level. Please send me an email and I can share with what you've done. But basically, we've got a comprehensive resource here that covers 1,000 illnesses, 32 medical specialties. So it's a matter of simply mapping the nodes in the curriculum to the relevant content in BMJ best practice and then making them available to the medical students or to the postgraduate trainees. So yes, we have that. How could we provide protocols for patients with multiple comorbidities? That's a question from Reem. Thank you, Reem. So if you send me an email, I'm happy to give you guest access to some of the content and you'll see how it works. You go to the treatment algorithm for a patient with an acute condition and you add one or more, and you can add up to all comorbidities, 9 or 10 of them if you wish to. And then the treatment algorithm or protocol evolves, it becomes dynamic in light of that. And it will advise how to manage a patient with all these multiple illnesses. Just move on to the next question. Another question from Reem, thank you. How can we raise the awareness of our students to the issue of guidelines for multiple comorbidities? So I think that's a really important question, actually, because too much undergraduate medical education is still focused on patients with single diseases. And it's only when medical students make the transition to becoming doctors or residents that they're faced by the challenge. So I think it's partly through providing resources such as this, BMJ Best Practice Comorbidities Manager, but also thinking about how we provide education for team-based care as well, and also because team-based care is required for patients with multiple illnesses. And also, I would say communication skills are all important as well. They're important for every patient, but particularly so for patients with multiple illnesses. So thank you, Shafqat. Will this approach increase costs in private setups? So I think the opposite is true. I think that this approach is much more likely to save costs because it avoids complications, it avoids harm, and it avoids prolonged lengths of stay. When comorbidities are neglected or not taken into account, patients commonly develop complications, and they're also associated with prolonged length of stay. And we have multiple examples from individual users in the UK who've told us they've used the tool and been able to prevent complications and reduce length of stay and sometimes avoid hospital admission, full stop. So I think it's much more likely that this approach will enable doctors and other healthcare professionals to rationalize the treatment regimen and the investigations protocols and reduce length of stay and indeed save costs. Another question from anonymous attendee, how often is it updated? So that's a really important question because of course content to be evidence-based has to be continually updated, has to be current. So we've got a team internally at BMJ who are continually updating the content. The content is updated every day. When new evidence or guidelines come to light, we incorporate it into the content. We've got an internal team starting from information specialists working all the way up to senior clinical and pharmacist editors who are updating the content, but on also external team of contributors, authors, peer reviewers, external panel members who are continually updating the content as well. But it's an important question about updating. I just go back to the chat. So I don't think there are any other questions, but thanks to everybody who did contribute to the Q&A and the chat. And you're absolutely right, Reen, the purpose is to improve the quality of care and indeed save lives. I think we've got another question. Does BMJ approach include symptoms like vomiting or constipation? So the short answer is yes, it does. So BMJ best practice will provide guidance on how to manage clinical conditions, like it'll tell you how to manage patients with diabetes or diagnose type 2 diabetes, perhaps, so disease-specific guidance, but also if you're not too sure what the diagnosis is, and so you need to assess a patient with vomiting or constipation, with signs such as peripheral edema, or with test results such as hypocalcemia, then yeah, whether it's cough or clubbing or abnormal calcium levels, BMJ best practice will be able to help. It's not just disease specific. There are assessment of or evaluation of resources on there too. I think we have answered all the questions, unless anybody else has any questions. Once again, please do get in touch. Be very happy to provide guest access to anybody who'd like to have a look. And indeed, what we're ultimately trying to do is to provide this to institutions, which might be medical schools or postgraduate training authorities or hospitals or other healthcare providers, so that members of that institution can then access the content under the umbrella of that institutional subscription. That's what we're trying to do. So please do get in touch if you would like this for your institution. I don't think there's any further questions at the moment, so I'm going to hand back to the host. Mohammed, if you want to take things over from here.
Thank you.
Okay, we've got one last question actually, which is an important question. I've got time. I'll try and answer it, from Abdullah. Where do you think such guidelines are situated medically if it was applied by non-specialized healthcare professional? Well, first of all, I should say that our resources are aimed at healthcare professionals, are aimed at professionals and not lay people. The situation medical legally, specifically to answer that question, is that we provide guidance and support. BMJ best practice is not a robot. It doesn't actually make decisions about care. It offers guidance and clinical decision support, with the emphasis on support, which the healthcare professional then interprets and hopefully puts into practice for the benefit of patients. So such an issue we'd hope would not arise. Like, I think generally, if you look at things in the round and stand back, medical legal problems are much more likely to arise when clinicians do not provide evidence-based care than when they do provide evidence-based care. So we'd hope that shouldn't be an issue.